Hi, welcome to Pharmacology of the Synapse. In this third video on genetic predisposition of disease, we'll explore the treatments for Fragile X syndrome. The first issue is just how to treat a genetic disorder. Basically, non-pharmacological treatments to address the symptoms of Fragile X syndrome are the main line of therapy. After diagnosis, early interventions for children can help improve their motor, communication, and social skills. Pharmacological treatment of symptoms is also used. For example, anti-seizure medications to reduce the frequency or severity of seizures in patients, and medications to control attention deficits. Pharmacological treatments for the underlying cause of Fragile X syndrome are still in the testing phase. We'll take a look at some treatments that have targeted the mGluR system. In our last video, we examined the glutamatergic hypothesis of Fragile X syndrome, where loss of FMRP accelerates the AMPA internalization that is caused by mGluR5 signaling. Inhibiting mGluR5 receptors is a good strategy to try and treat the underlying changes caused by loss of the FMRR protein. In preclinical research, MPEP and CTEP are mGluR5 inhibitors that are frequently used. MPEP is a non-competitive antagonist, whereas CTEP is an allosteric antagonist of mGluR5. Clinically, phenobam and mavoglurant are drugs that have been used and are the ones that we will examine later on. In preclinical studies, CTEP has been shown to correct the dendritic phenotype observed in FMR1 knockout animals. In panel B of the figure, you can see the reduction in dendritic spines in the CTEP-treated knockout mouse, and this is a significant difference when quantified in panel C. Inhibitors of mGluR5, such as MPEP, also restore behavioral deficits in preclinical models. One of the behavioral measures that can be performed in mice and humans is a pre-pulse inhibition measurement. The PPI measures the suppression of an auditory startle response. So for example, if a sudden loud noise is played, this will cause a startle response. If you play a second sudden loud noise right after the first one, then the startle response to the second sound will be dampened because of a phenomenon called paired pulse inhibition. PPI is impaired in patients with Fragile X syndrome and other neurological disorders such as schizophrenia. In preclinical models, the mGluR5 inhibitor MPEP can increase PPI in FMR1 knockout mice. So far, the preclinical data looks promising. The first trial of an mGluR5 inhibitor in humans used a single oral dose of phenobam, which is a negative allosteric modulator of mGluR5. This was an exploratory open-label trial of 6 men and 6 women, aged 19 to 31. This means that no placebo group was used. Everyone received phenobam. The major finding of this trial was the fact that no serious adverse events occurred. Most of the patients did show some improvement on their first paired pulse inhibition measurement, although the repeated test did not show improvement for most patients. The next major trial used was mavoglurant, which is an antagonist of mGluR5. This trial was the first gold standard double-blind placebo-controlled trial. It was 12 weeks long with 175 adult patients. Groups were even stratified based on the methylation status of the FMR1 gene. The major results from this trial was that there were no major adverse events, but also no beneficial cognitive improvements on the ABCFX scale, which is an aberrant behavior checklist for Fragile X. Perhaps the patients were too old in this trial, so the next trial enrolled adolescents. This second clinical trial enrolled 139 adolescents aged 12 to 17 for a 12-week study. Again, they did not find any significant improvements on the ABCFX scale. Essentially, the mavoglurant trials were failures with no significant improvement. Some of the lessons learned: and unanswered questions that these trials raise are the length of the drug treatment. Perhaps 12 weeks is not enough. Maybe a younger patient age is required, and adolescents are already too old to reverse some of the effects. Maybe mGlu inhibitors are not the most effective treatment option, even though there is preclinical data supporting the inhibition of mGlu5 receptors in reversing the dendritic phenotype in Fragile X syndrome animal models. Alternatively, other abnormalities in Fragile X syndrome can be targeted, such as the downregulated GABA and dopamine signaling. There are still a lot of things that can be tested to see if they have a beneficial effect for Fragile X syndrome patients.